what am I going to tell you? Because Sube said it's very complicated. And I think we have a start of something simple. And I'm not going to sell you anything. So the government doesn't, but okay. Improving crisis and care coordination. Okay, is this better? Yes. The EU joint action on dementia. Well, that's my slide. Okay. What am I going to tell you? I'm telling you something about the work package 5 within this joint action, crisis and care coordination. What did we do in that work package and the implementation of our findings? So the work package 5 in care, crisis and care coordination. Its members were Italy, Bulgaria, France, Scotland, and the Netherlands. And Italy and the Netherlands were joint work package leads. And the objective for this work package was, and that's really a mouthful, to provide the EU member states with clear evidence-based and tested information and recommendations on how to effect change and improvement in care coordination and crisis response services for people with dementia living at home. Okay, well, what does that mean? Well, at first we took a mapping exercise. We identified relevant research on practices of dementia, crisis and care coordination, including an update on the ALCOVE research, which was the first joint action on dementia, on BPSD. And as a result, we identified the key principles and best practices in care coordination and crisis response services for people with dementia. And there were quite a lot of key principles and best practices. So it was another task to identify the best methods for crisis and care coordination in the participating countries. And these best methods turned out to be case management and care for BPSD to mobile teams and psychosocial interventions. And one of the common outcomes was, of those methods, you need a multidisciplinary approach. Perhaps you need medication, but that's not the first one. Whether you have a mobile team or a team in a residential or clinical setting, it has to be multidisciplinary, with at least an elderly care physician, a psychologist, a psychiatrist, and district nurses or case managers, depending on the country you're living in. And well, having said that, it was the fact, what are we going to do? Because it's nice to have all the literature, but if you want people with dementia and their relatives to be helped with this knowledge, you have to implement it. And that's what we did. And implementation was different in each participating country. You can imagine that almost every country has a different type of care setting of the care available, and also in the knowledge and awareness about dementia. So in Bulgaria, they started education programs for general practitioners and caregivers, just starting with basics. What is dementia? How do you recognize it? What are symptoms? What to expect? And how to act on a person with dementia. In France, they already had more experience in working for better care for people with dementia. And they trained nurses assistants at GP practices to deal with BPSD. And they had multidisciplinary mobile teams. As you can imagine, that a rural setting in France won't have a similar amount of care available and specialist care available when you're living in Paris or a city like that. And in Italy, where we have another different system with much more a regional approach, they introduced a system for management of BPSD on a regional level and based from a hospital. So in practice, persons with dementia would have to go to a regional hospital to have treatment or assessment of their BPSD and the causes of the crisis. Scotland, well, no longer part of the EU, unfortunately, but still part of Europe, Subi. It's just still on the continent, although you're an island, but indeed, but you're a bit part of us. Scotland had a post-diagnostic support set up in primary care projects. That's part of the NHS. And in the Netherlands, we trained case managers in networks for coordinated dementia care, because already in 2007, we started to form regional networks for integrated dementia care. And the case managers working there were happy to work further on crisis and even improve the care coordination. And they, well, the selected networks we worked with for this implementation were having a coordinated dementia care in combination with dementia expertise centers, the so-called DEC centers, where they indeed already had primary care physicians, elderly care physicians, psychiatrists, psychologists, and case managers. So we were a bit ahead, but nevertheless, there's always room for improvement. And when we implemented in the Netherlands, we trained the case managers, and as soon turned out, it's never easy, that we need a differentiated approach, depending on the individual living with dementia and the stage of their dementia, and of course the type of dementia, because frontotemporal dementia differs clearly from Alzheimer's or from cardiovascular dementia, just to name a few, as we have so many. That's and of course, like Subi said, there are so many types of agitation, whether you call it BPSD or not, and there are many differences. So behavior like repeatedly asking the same question, agitation, is far different from delusions and severe anxiety, where you sooner would need psychiatric help than help from a case manager. Then it's the task of a case manager to say, okay, this is beyond my knowledge and we have to refer further. And the case managers were often called to assist in cases of BPSD, and only too often they were called late, they felt, when the behavior led to a crisis or a near crisis. Oh, those caretakers are so busy, we shouldn't call them if there's just a little issue. Families cope until they can't cope anymore, and it was too late. And the case managers also felt being behind in times. Although they got a training to act on BPSD and crisis, they rather wanted to prevent BPSD. And that's where the Netherlands took a next step and developed a different training, another training to prevent BPSD. And the main point coming from this training was that prevention has to be personalized, like every sort of care, depending on the person, their identity, the type of dementia, and its stage. And so every case manager in the Dutch case will have to get to know the person living with dementia, their habits, their likings, and the things they don't like. If you have to do, Subi told you, and Sirpa as well, if you have to do things you don't like or isn't a response to what you experience, you get agitated. We would. So a person with dementia does as well. Like a story I heard about a lady in a nursing home. Okay, I'm talking about care at home, but a nursing home. And they played always those Dutch popular songs in the living room. And she got really agitated. And staff said, well, that's what she does always. Just leave her. And then the young nurse said, well, I'll just talk to her. And then it turned out she hated those popular songs and loved to listen to classical music. So this young nurse took an iPod with headphones and said, here's some Mozart. There was no problem anymore. And sometimes it can be that simple. It's not always that simple, of course. That's, And okay, what they don't like. And it goes without saying that you start by talking to the person living with dementia. That's the first one you turn to when you want to know what they like to do and what they want and what their needs are. And only after that, you can consult the persons near to this person and find out what they need. And this may take time. And this is a challenge for a care professional. Yes. They often don't have so much time to spend on a client. We all know how it works. And although it will save time at a later moment, this is the dilemma of prevention. Luckily, some care providers recognize the importance of prevention and allow time for the training of case managers and allow time for the prevention activities after the training. And maybe not really surprising, it turned out that clear information on dementia, what to expect, combined with a feeling of belonging, to still matter to those near to them and for society, and having meaningful activities which they like in a familiar surrounding are important ingredients to prevent BPSD and agitation and to prevent a crisis as a result of that. And to conclude, we cannot prevent every case of crisis, but we can make significant progress by acknowledging persons living with dementia as dignified members of society and giving them the opportunity to perform meaningful activities. And how to do that is the next chapter. And for now, thank you.